Good morning, everyone. As a reminder, due to the International Certification Quality Program our resident is part of from CONACYT, today's lecture is going to be made in English. The class we prepared for you today is Vascular Anatomy of the Pulmonary Trunks and Disease. My name is Claudio Alberto Casas, and the advising teacher is Dr. Matías Salinas. The class is divided in 3 different sections. We're going to talk about the radiological approach to pulmonary vessels, a vascular pulmonary anatomy, its implications for imaging. We're going to talk about the systemic vessels and the ileum as well, and the diseases of the pulmonary vasculature. For starters, the basic chest X-ray, it's still a useful tool for visualizing all the pulmonary vessels, as well as many other things like a general view of the cardiac and pulmonary variants in pathology. You can see the aortopulmonary window, some vascular interfaces, you can evaluate masses, and you can even do some different measures. The cardiothoracic ratio, the vascular pedicle over here, and the width of certain arteries and veins that we're going to talk about later on. This is the first this is going to be always the first study we're going to have, and it's still a useful tool. But if we want to do a CT to assess the pulmonary vasculature, the enhanced arterial CT is the way to go. There are certain requisites to obtain a good view, and therefore the best level of detail. Like this example, this is a coronal view plus maximum intensity projection that lets us evaluate the further arterial anatomy that the pulmonary vasculature can offer us. And these requisites are some of the following. We have to get a power injection of 80 to 120 millimeters at a speed of 3 to 5 millimeters per second. Sometimes you have to make the arterial phase for 20-25 seconds after the first push. There's some articles that say that the 15 seconds is the best way. You have to take a delay scans if you want to assess central veins in vascular masses. There's still a post-processing at certain workstations, so we can see the maximum intensity projection, like in this example. And there's a thing that you have to evaluate the pulmonary artery embolism. You have to make a different protocol than those to evaluate bronchial arteries, and that is because the pulmonary artery embolism protocols consists in a scan from the diaphragm to the apex in a caudocranial way, so we can observe the lower lobe vessels, because in this part of time, and you have the best enhancement and the optimal breath holding. We have to remember this is a patient that is suspected an embolism, therefore he has dyspnea. And the same goes if you want to see the best bronchial arterial anatomy. You have to scan the patient in a craniocaudal way. Sometimes you use special softwares like cardiac triggering to get even to get a sustained way to watch this vasculature. If we talk about MRI, it's useful to if we always use gadolinium to get good images, but its intrinsic black block nature of some of the sequences can help us identify vascular central tumors and thrombi. And since the acquisitions in TOF, the 3D TOF, conventional time of flight and geographic techniques are too long, there is still a signal loss in some of the planes. So there's been some research of some breath hold fast 3-dimensional gradient echo time resolved sequences that helps us with plus a bolus of gadolinium help us get this type of architecture of the pulmonary vasculature. Here we can see the pulmonary trunk, the right pulmonary arterial vessel, and some of the pulmonary veins over here with the arrow. These new techniques are really fast. They require ultra-fast scanners and to keep track of the bolus of gadolinium in each time of the pulmonary circuit. still a gold standard for some of the of pathologies and some of the evaluation of vascular anatomy. The angiography has some special indications. You have to get a careful assessment beforehand, especially with electrocardiogram, because there is a transient right bundle block when you do there can be a transient right bundle block, heart block when you do the angiography. And if the patient already has a left bundle branch block, you can end having a complete heart blockage. So it's always important to check this kind of diseases before making an angiography. As you know, you can have a femoral or jugular venous approach, and actually the angiography is still the gold standard to check some diseases, because you can measure the pulmonary artery before contrast, and you can measure the pressures. Another thing is that there's a normal rate of contrast that you have to use in each time of the angiography. The normal rates are 25 to 30 millimeters per second for 2 seconds. But the thing is, if you have an uncompensated pulmonary hypertension, you have to decrease the volumes of contrast injection to avoid right ventricular acute insufficiency. There's a trick when you do the angiography that you have to evaluate the flow times. If you have a brisk flow, even in the setting of extremely elevated pressures, it indicates a right ventricular function that is adequate. But if you see a slow flow in a patient that doesn't have tachycardia, it indicates there's a right ventricular insufficiency, and therefore you got to diminish the amount of contrast you're going to use in the pulmonary angiography. As you know, you have the arterial phase and the venous phase, like all the angiographies you study. Now I just need one brave volunteer to explain to me the interfaces that a normal chest X-ray gives us. Anyone?
Okay.
Dr. Javier, don't worry, bro, I got you. Here.
Okay, we have two images. The left one is a diagram of the heart. The right one is another diagram, but with an X-ray. Okay, we can see the right border of the heart. It corresponds to the right atrium.
Okay, yes.
We can see how the superior and inferior vena cava drain into right atrium. On the left side, the left border, we can see the left ventricle. On the upside of the heart, we can see the aorta, the aortic arch. Down the aorta, we can see the left ilium, where we can see also the pulmonary artery, the left pulmonary artery. And between the aortic arch and the main pulmonary artery, we can see the aortic pulmonary window, which is an important zone to mention, because if we see an opacity there, that
it can correspond to certain diseases.
Yes, that's right.
Okay.
Like, I don't know, it can be a mass, it can be a lymphadenopathy, or it can be an arteriovenous disease. But
okay.
What else?
Excellent. No, excellent. Thank you very much. Well, yeah, as Dr. Javier just explained, there's certain vascular interfaces that we can assess through a normal chest X-ray. And well, we're going to talk about systemic vessels, but Dr. Franklin already gave us a really good class about the congenital variants of the aorta and their anomalies. If you want to know a little bit more, please go to the link below and check on all the aorta and its branches. And what we haven't talked about that much is about the bronchial arteries. And well, some classes before we talked about a little bit, but we're gonna make like a little summary of it. And I put like a systemic vessel. If it's considered a systemic vessel, well, personally, I like to say it's a mixed vessel, because it's part of the systemic circulation, but provides the respiratory system with oxygenated blood at 1% of the cardiac output. There are branches of the thoracic aorta And as we said before, we already discussed them. Well, I'm just going to say the summary that we have to divide them in orthopic or ectopic. An orthopic bronchial artery is an artery that goes from T5 to T6. If it's not born into this anatomy, it's considered an ectopic. And while all bronchial arteries by definition, doesn't matter where they start, they're parallel to central airways and enter the lungs at the ileum. This is the way that you can observe them through some of the studies. It's important to remember that it has to be less than 1.5 millimeters of diameter at its origin, and it decreases as it goes further. The 64% of all bronchial arteries are ectopic, and there's already a classification made by Caldwell and his collaborators that gave us a lot of different variations that Dr. Haas said a little classes before. 36% of the other bronchial arteries are ectopic. Always have to remember that 10% of the communication have communication with the artery of Adam Kiewitz. Here's an example of an ectopic artery that is arising superiorly from the aortic arch between the left common carotid and the left subclavian arteries. This is the 45%, the Caldwell 1 orthopic anatomy. And as I told you before, Caldwell described actually like 9 patterns of different configuration of the normal anatomy. It's divided 21, and 10%, already discussed in classes before. I'm going to go faster in this. And I'm just going to go to emphasize on the bronchial artery hypertrophy and dilatation, because this is the main cause of hemoptysis on patients. If you visualize some bronchial arteries, it suggests decreased pulmonary flow. And the radiologist should be able to assess the pathology of bronchial arteries. The most common pathology is this one. It's the source of bleeding with 90% of the patient with hemoptysis. And in this example, in this angiography, we can observe that there's some hypertrophied right and left bronchial arteries in a patient that was with cystic fibrosis. And in this actual contrast tomography shows us a patient diagnosed with Takayasu disease, an increased pulmonary trunk, plus some of the bronchial artery dilatation. And in this patient with chronic arterial pulmonary embolism, it shows an extreme bronchial pulmonary dilatation that happens to be in a patient, as I told you, with decreased pulmonary blood flow. It doesn't matter the cause. And if it comes to the causes, Walker and his collaborators classified 5 pathophysiological categories that cause the bronchial artery dilatation. Some of these categories were the congenital pulmonary artery obstruction or anomalies, acquired intrinsic or acquired extrinsic pulmonary artery obstruction, chronic or acute inflammation, and pulmonary hypertension. He even described the most common pathologies and the degree of dilatation that it might cause in the bronchial arteries. As we can see here, seeing that tetralogy of Fallot and some of the proximal interruption of the pulmonary artery, doesn't matter the cause, are the causes that dilatate or hypertrophize more the bronchial artery. If we have an hemoptysis, besides the bronchial arterial hypertrophy, we have to remember there are different diagnoses like pulmonary infarct, pulmonary artery cellular aneurysms or arteriovenous malformations, malignancy, some other not pulmonary causes. In this angiography, digital subtraction angiography, we can see the characteristic parenchymal stain caused by the extravasation of contrast to the lung parenchyma. And after embolization procedure, you can see that there's no more stain on the pulmonary blood flow. If we talk about the veins, we have to remember that the superior vena cava is formed by the anastomosis of the left brachiocephalic vein and the right brachiocephalic vein. A distal portion is partially invested by pericardium and it drains into the right atrium that should be here. The inferior vena cava cruises through the diaphragm into the right atrium and is partially invested by pericardium. We can observe a normal unilateral chest radiograph. We can see the thoracic aorta that we already talked about, and we can evaluate as well the inferior vena cava is one of the ways. Besides, we have also some of the interfaces that can be assessed through the lateral chest X-ray. Another thing important in the systemic vessels is the Icicle System, that consists on the azygous vein, the hemiazygous vein, and the accessory azygous vein. The azygous vein drains the posterior chest and abdominal walls and the mediastinum, and may drain the lower body in cases of the inferior vena cava obstruction. It ascends as it goes here from T12 to T5. It goes right over the right mainstem bronchus to drain to the posterior aspect of the superior vena cava. This is called the azygous arch. And the hemiazygous vein is this little one here that crosses to T9, and over T9 it goes to the azygous vein and creates its anastomosis at this level. The accessory hemiazygous vein is this one here that descends from the left side of the anterior aspect of T4 to T8, and it also connects to the Icicle System. We can see in a normal chest X-ray as well the azygous arch and the acygal esophageal fissure or recess, as well as in this sagittal reconstructed tomography. We can observe how the azygous arch comes over the right mainstem bronchus. This is important because there are some anomalies, some very anomalies of the venous systemic vessel, as the persistent left superior vena cava here. You can see it's full with contrast, or the persistent left superior vena cava with an persistent or with a normal right superior vena cava. You can see here in this example how both vena cavas coexist. You can also have a persistent left superior vena cava with an hemiazygous continuation or an azygous continuation of the inferior vena cava. Here, in this anatomy, it is not enhanced and continues over the bottom, the inferior vena cava through the azygous, and it is, as you can see in this coronal view, it is associated with polysplenia and isomerisms, as well as the hemiazygous continuation of the inferior vena cava that is associated with abdominal isomerisms. You can see here a right-sided spleen with the liver over there. So just to mention a little bit, we also have to consider the lymphatics as part of the vascular system. And at this level, you can observe the thoracic duct and its normal width. It ascends, it rises from the cisterna achilli that is over here near the L2 vertebra and crosses left to drain over the left jugular and subclavian and vein anastomosis. In an upper level, we can observe it that it is a little bit wider. And if you want to watch the anastomosis, it's explained over here where it drains over the subclavian and jugular vein. Now, to understand the ileum, we have to remember that it's considered the roots of the lungs and is surrounded by mediastinal pleura and mediastinal pleura reflections, which extend inferiorly as the pulmonary ligaments over here. It's the point of connection between the lung and the mediastinum, and the bronchial, the vessels, and many other structures pass through it. You can see this is a figure that shows the depiction of the ileum. More importantly, we see these sagittal reconstructions. We can highlight the right and the left ileum, its central location on the mediastinal lung surface, and the relative location of its various components. As the right superior pulmonary veins on the front part, on the right side of the ileum, the pulmonary arteries between the veins and the right-sided bronchi, and the right inferior pulmonary vein going in the lower part. Here in this cellular reconstruction CT, in this close-up, we can understand it this way. As well as the other part of the left ileum, it shows the left superior pulmonary vein on the anterior part, on the posterior part, the left bronchi, on the inferior part, the left inferior pulmonary vein, and parallel to the left mainstem bronchus goes the left pulmonary artery, showed in this graph over here. So we already talked about some of the X-rays, but the evaluation of the ileum has some particular things. We can understand in anatomic structures through the right and the left ileum. We have special signs, so we can identify masses like the ileum overlay or the ileum convergence sign. In the lateral chest radiograph, we can understand this intermediate stem line. And we can evaluate the height, its opacity, or if it's enlargement, as well as the width of that normal interlobar right-sided artery. Now going further, we have to we start on the pulmonary vessels. The main pulmonary artery pressure it's normally 22 to /8 millimeters per mercury, with a mean pressure of 13 millimeters of mercury. It has an enormous capillary bed of 90 square meters of, and then simple diameter from 8 to 9 micromillimeters. It is in charge of the gas exchange and as well the filtration of the solid waste. There's point, any time of point, it says that 30% of the pulmonary blood is in the arteries, 20% in the capillaries, and 50% over the veins. The right-sided pulmonary arteries, in its anterior view, we can see the right pulmonary artery arising from the pulmonary trunk and bifurcating into ascending and descending interlobar branches. Here showed very well here in this angiography, and now we have the venous phase, and we can show the superior pulmonary vein that curses anterior to the live upper lobe bronchi, and the inferior the right inferior pulmonary vein. Here, seen here, and on the left side. It shows the curves over the ipsilateral mainstem bronchus and its branches. And shows how the left-sided pulmonary artery goes over the left-sided bronchi. It showed here in this digital angiography, and in its venous phase, you can observe both the venous the pulmonary veins. Sometimes there's this inferior part of the arterial vascular pulmonary vascular arterial left-sided shows this is the branch of the lingula for the lingula. So well, how do we're gonna explain the pulmonary vasculature? And well, we have a combination of the voided nomenclature of the tracheobronchial tree and the Jackson-Uber systematization of the segmental lung anatomy. And using both this, they decided to make a nomenclature that gives a specific analogous to bronchial nomenclature, a specific name for each vein and artery, even in the distal 6 order parts. It consists on giving an L for left, an R for right, an A for artery, a V for vein, and plus a numerical number, analogous to the bronchial nomenclature. So as it goes further, you add an A or B if it's a segmental or subsegmental way. Here's an example of how the veins and the arteries are going to be named for this nomenclature. We can't continue to talk about the vascular anatomy without mentioning what occurs, where the magic occurs, right? In the second pulmonary lobule. We know it's 1 to 2.5 centimeters in its polyhedrical shape. It's the basic anatomic unit, and it has a central artery and peripheral veins and lymphatics. It is important because central pathology make them appear on imaging. These peripheral veins and lymphatics. Anyone wants to say how it's called? When these are enlarged, you can see them in a CT. Huh? When you have, there's certain pathology that dilatates the veins and the lymphatics, and this is called the interlobular septa, and this is well seen in central pathology, and it's caused by edema, inflammation, or injury. Understanding this specific anatomy will help us to provide a different differential diagnosis depending on the pathology we're assessing. The pulmonary lymphatic channels drain to different nodal stations, and we can variably observe the lymph node intrapulmonary, but these lymph node stations are important for some cancer staging. As a summary, we have to say that N1 stations are from distal to the mediastinal reflection within the visceral pleura, and all N2 stations are within this mediastinal envelope, within the mediastinal pleural envelope. Another thing is that almost every artery that supplies the thorax, including the diaphragm, can provide a collateral supply to the pulmonary arteries. And like in these examples, you can see how this was a iatrogenic pulmonary artery occlusion following a right lobar lobectomy, and afterwards in the digital angiography, you can see how so much of the intercostal and bronchial arteries started supplying the right sided lung, what was left of the right sided lung. There are certain anomalies of the vascular arteries, like the absence of the main pulmonary artery. In this syndrome, we can see that it's called the Macleod Syndrome. It shows how there was no pulmonary artery born here, and the opacity is well demarcated. It's less demarcated than over the left side. We also have to consider the anomalous origin of the left pulmonary artery, like in this example, that it is considered a pulmonary artery sling. We also can have pulmonary artery stenosis or coarctation or congenital aneurysms. When it comes to the veins, there's a lot of variations on the pulmonary veins as a result of its embryological development, and it is from the left atrium, and it's under or over incorporation of the veins depending on the stage of separation from the left atrium. The most common anatomies occur when in this graphic denotes how the most common anatomies occur when B development occurs, giving us two different veins, but it can over-incorporate if it goes over the C anatomy and gives it's more common on the left side and can give us even four veins, or it can become supernumerary and go to the A type of differentiation and gives us a common trunk. There's frequent variations of the middle lobe pulmonary vein, and this is significant. Why? Because there's certain ablation techniques that require the vein anatomy. So when to understand where to put the ablation for a rhomogenic foci. So it's important to understand this type of anatomy and report it. Besides the variants of the anatomy, we could have the pulmonary barracks, like in this example, is represented as a simple pulmonary nodule that after an arterial phase, it shows the enlargement of the segment of the pulmonary vein, or we can see an opacity on the arteriopulmonary window that has three different possibilities. Anyone knows what are the three different possibilities? Dr. Javier just said it.
Okay, it could be a vascular abnormality.
Yes.
It could be a mass.
Okay.
Lymphadenopathy.
Yes, those are the three basic possibilities of opacification on the arteriopulmonary window. And in this case, it was partial anomalous pulmonary venous return from the left-sided pulmonary vein, the upper left-sided pulmonary vein, to the brachiocephalic artery. And we also can have the congenital venous lobar syndrome, that it's as well anomalous pulmonary venous drainage, but to the hepatic or the inferior vena cava veins. It's called the scimitar syndrome, that's showed here in the, because of the shape of the venous anatomy. We can have mixed anomalies, like the pulmonary arteriovenous malformation. It can be congenital or it can be acquired. In the congenital form, you can see here it shows in this tomography, we can observe this nodule that has some projections over, and when it was placed an angiographic technique through this nodule, it was shown how's it said? Left to right shunt, decreased size artery, and dilated vein over here. Yes, some of these arteriovenous malformations, almost 40 to 60% of them are related to the Osler-Weber-Brandu disease. And the hepatopulmonary syndrome, it is an acquired malformation characterized for extreme or end-stage liver disease that makes the lung want to supply the diseased liver with some oxygen, and that makes some of the vasculature, arterial and venous vasculature of the lung, go through the liver and make some abnormal connections. This is an hepatopulmonary syndrome, and it's an acquired form. Just to mention some of also congenital lymphatic anomalies, we have formational lymphangiectasia, localized lymphangioma, diffuse lymphangiomatosis, or as Dr. Lorena likes to say, lymphangiomyomatosis. We're not going to talk about them in this section. And now the diseases of the pulmonary vasculature, I separated them into four basic pathologies. The pulmonary artery hypertension, it can be divided in precapillary or postcapillary. The pulmonary thromboembolism, it can be acute or chronic. Congestive heart failure, which is one of the it's one of the end phases of the. It can be one of the end phases of the venous hypertension, postcapillary, and other diseases. It is important for understanding the pulmonary artery hypertension, the definition. The definition is made by a Swan-Ganz catheter placed over the pulmonary artery, and it has to measure the mean pulmonary artery pressure. It has to be, it is more than 25 millimeters per mercury at rest, and it is considered a pulmonary hypertension, or 30 if it's during exercise. There's pathologically, it is divided in depending on some stages, it is divided by the pathologist, and is characterized by dyspnea on exertion, fatigue, syncope, or chest pain. The idiopathic form is more commonly on the third decade of life. Male to female ratio is more common 3 times on the females than the males. And schistosomiasis is the most common cause worldwide, having like 25% of the cases in people over 65 years. Interestingly enough, the chronic thromboemboli is only considered 1% of the causes, and overall it has a poor prognosis. The causes of pulmonary arterial hypertension can be divided in precapillary or postcapillary. There are some pathophysiological way that has been used to understand the pathologies that end up in pulmonary arterial hypertension. It is considered in the precapillary is increased pulmonary blood flow or decreased cross-sectional area of the pulmonary vasculature, and postcapillary is increased resistant pulmonary venous drainage. It is important to understand these two types of pathophysiology because there are some radiological aspects that we can have specifically on the postcapillary causes of pulmonary arterial hypertension. For example, in the precapillary causes, we can see a marked enlargement of the main ileal pulmonary arteries. The interlobar artery, it has to be equal or less than 60 millimeters. If it goes over that, it is considered pathological. In this chest X-ray, we can see how the arteries, the pulmonary arteries, taper distally and show less flow. Or we can have this is called a disparity in size of the central and the peripheral pulmonary arteries. This is this is an X-ray of a person that had a more advanced disease and shows a huge enlargement of the pulmonary arteries, and this is easily diagnosed. On the CT findings, the most important thing is evaluate the enlargement of the pulmonary trunk. It has to be less than 30 millimeters. Certain articles say that at 28, it's still on debate. And the high resolution CT helps us search the etiological source. Since if we have a high CT, like in this case, was a person with emphysema, and this was the cause of this arterial hypertension. Or you can understand if it's a chronic pulmonary arterial hypertension, we will see some hepatic ground glass opacities and some focal decreased blood flow and mosaic pattern anatomy on the pulmonary view, as well as postcapillary etiologies that we're going to talk about in next sections. There are other diagnostic methods like the MRIs. We use a phase contrast technique. In this sagittal MRI with phase contrast technique, we can see the enlarged pulmonary trunk and the enlarged pulmonary left and right arteries. It is useful because you can, besides evaluating the morphology of the artery, you can determine the direction, the velocities of the flow. Angiography, it's still one of the gold standards, since through angiography you can measure the pressures, and in nuclear medicine you can use some of the nuclear medicine techniques for chronic thromboemboli, like ventilation perfusion scintigraphy that we're going to talk about a little bit on the next parts. If we have an enlarged pulmonary artery, there are some 5 or 6 pathologies we have to consider. The most common differential diagnosis is pulmonary artery hypertension, pulmonic valvular stenosis, or atrial septal defect. Less commonly, we could have an Takayasu arteritis or a pulmonary artery aneurysm. And rarely, but important, we can have a mitral stenosis or regurgitation, a pulmonary veno-occlusive disease. That this is exclusively a postcapillary idiopathic disease, or pulmonary hemangiomatosis. In this example, this is an example of a patient that had Takayasu disease, and it shows that enlarged pulmonary trunk and some stents used because of the acquired stenosis of the pulmonary arteries that was being made by the disease. If we have a postcapillary venous hypertension, we should understand there are certain characteristics that a normal chest X-ray will give us. It's called the cephalization of the normal pulmonary vasculature, or the recruitment of upper lobe vessels. And this term refers that there is an increased caliber of the upper lobe vessels, which results in the diversion of the blood flow. This reversal is gravity dependent and increases caliber of the lower lobe vessels seen on the upright radiograph of normal individuals. It's completely normal, but the cephalization of the pulmonary vasculature will convert this pattern in the opposite, and you could see this pattern is best evaluated in upright radiographs. You have to remember that in this type of pattern, we're always going to have arteries larger than bronchi in the distal parts. We can understand interstitial edema and hemosiderosis and fibrosis. The interstitial edema is like it shows like an excess of extravascular fluid within the interstitial space, and you can see the bronchopulmonary bundles, like in this radiograph, that are more dilated. B and A curly lines, as we said, normally on that happens because there's edema over the interlobular septa, and if this continues, it can convert into alveolar edema. Alveolar edema advances and is considered pulmonary edema, and it's like in these two radiographs. The thing is that alveolar edema has a gravitational effect, so that's some of the ways that we can differentiate it with other pathologies that consolidate the lungs. This is a different different radiography in the same patient on 2-hour difference in a patient that was placed on the right side and on the left side, and as you can see, all the edema and opacification was moved from one space to another. This is one of the ways that we can differentiate it with other consolidation causes. And interstitial edema, as I said before, it's like a scaling. It goes first interstitial and then alveolar edema. And well, there are other causes of pulmonary edema, but this is not about this topic. Maybe someday we're going to talk about them later. And there is a physiological relation on the radiographic findings of the pulmonary venous hypertension and the congestive heart failure with the physiological parameters or capillary or venous wedge pressure. It is said that if you have a capillary or venous wedge pressure higher than the normal is from 8 to 12, you have it higher, like 12 to 18, it leads up to cephalization of the upper lobes. If you have from 19 to 25, it leads to interstitial edema, curly lines seen on 17, and pleural effusion seen on 20. And if you have an elevation superiorly to the 22 millimeters per mercury, you have a nurse space consolidation and therefore alveolar edema. That's for pulmonary hypertension. On thromboembolism, we have to understand this virtual triad. We have seen it a lot of times before. It is one of the causes. One of the causes that describes pathophysiologically the creation of the thrombi. And we have to understand that the third common cause of acute cardiovascular disease is thromboembolism. It is characterized by dyspnea, pleuritic chest pain, tachypnea, and tachycardia. It can be acute, and 1% is considered recurrent, therefore chronic. And 50% result in infarction, and this is important because just 50% of the chest X-rays, because of the infarction, are gonna show clinical signs. It's gonna show radiological signs, and the D-dimer, it's good to disqualify the thromboemboli. If you have a negative D-dimer, there's little possibility that you might have a acute thromboembolism. But if you have a positive D-dimer, there are a lot of possibilities that there are a lot of etiologies that they can give us. As I told you, 85% are gonna have a normal chest radiography. But if that 50% sign is gonna give us the Westermann sign, it's caused like in this chest X-ray, focal oligoemia. We can also see the abrupt tapering or atelectasis of the vascular of the pleural arterial vasculature. We can also see the Hampton's hump, which is a consolidation pattern made because of an infarct of the pulmonary parenchyma. We can also have elevated diaphragms, atelectasis, or pleural effusion. In this, we can see the Hampton's hump, characteristic of a pulmonary infarct. The CT has a sensitivity and a specificity different depending on the study you search. It can goes from 53 to 100 or from 83 to 100. It depends on the technique, it depends on the technical radiologist, and it depends on what you want to observe. But there has been some key points that we have to understand to diagnose acute thromboembolism, because this is the acute part. First, we're gonna see an intraluminal filling with a sharp interface. Understand over here. Or we can see a partial filling. It's called a polo-ment sign or the railway sign. Railway, radiologists use railway signs for everything. This is one of the railway sign. And we can see as well the complete opacification of an artery with the enlarged side of with enlarged artery in the side of the impaction. This is also a classic thing of the acute pulmonary thromboembolism. And peripherally, we have to understand that the thrombi makes an acute angle with the walls of the arterial wall. This should be considered as acute pulmonary thromboembolism, and the CT also gives us a chance to evaluate the heart function. If we have an enlarged right ventricle, like seen here, it's one of the signs that this acute thromboembolism is severe, and it has to be assessed and treated immediately. I placed this little thing here that says that it is safe to withhold anticoagulation in patients with technically adequate negative CT pulmonary angiogram. And this has to give us a heads up, because if we say that there's no thromboembolism in a patient, the clinician has all the bibliographic sustenance to withhold anticoagulation, and this and if it had pulmonary thromboembolism, this might be very severe for the patient we are assessing. So this is an important thing to remember. Well, it's not. It's just good to understand something of the nuclear medicine, because of the time, I'm not going to explain it overall. You just have to understand that this is a normal ventilation perfusion scintigraphy, and this is an abnormal one as well. It has different phases. It depends on different things that are going to put via inhalation and via intravenously. And there has been a lot of studies, and one of the studies that appears more is the PIOPET study that says that its sensibility is 98%. So the use of nuclear medicine over acute thromboembolism or chronic thromboembolism is actually the same if we use the D-dimer. Actually the same. You have to understand the results that are going to be explained, or the conclusions this type of studies gives us is the high probability, intermediate probability, or low probability of acute pulmonary thromboembolism. It cannot it cannot specifically conclude that they have. It just talks about probabilities. We have to remember as well the Doppler evaluation of the leg veins. 10 to 20% of the persons without pulmonary embolism might have an asymptomatic lower leg thrombosis, and 50% with pulmonary thromboembolism have them. The angiography is still the gold standard for evaluating the pulmonary thromboembolism, as you can see here. Filling defect of the contrast over a thrombi. And well, the MRI, as I told you before, it can help because of the black blood nature. It can help us. In this case, it's a contrast MRI, but if it was a black blood nature, the thrombi will appear hyperintense. And it's a good way as well to evaluate the thromboembolism. Still, these techniques are not as good at the CT because of the practical way of approaching, and the practical way it's not, and it's easier, actually easier. We talk about chronic thromboembolism. We have to understand the clinical way. It's progressive dyspnea, emphatic, On the other hand, like acute pulmonary thromboembolism, you have a filling defect that enlarges the artery. In this case, we're going to have a filling defect that encloses and makes an artery a less part. The angles made on with the arterial lumen are obtuse. You can see as well partial recanalization with some thrombi over. I like to say it's like the contrary railway sign, because it's a partial canalization over the chronic thrombi. And as well, we can see normally in chronic pulmonary thromboembolism, we will see a pulmonary artery greater than 3 centimeters. There are a lot of causes of embolism, not just thrombotic, and they have some non-specific patterns. We have to understand the clinic to suggest this diagnosis. Like in this case, it was a fat embolism. It was a patient who sustained a motor vehicle accident and had these opacifications and this opacification on the lower lobes, and this was diagnosed as a fat embolism. Some case reports placed here said that this was one amniotic embolism in a patient who was pregnant. You can see a total opacification of the lungs. You can have tumor embolism with a certain enlargement of the interlobular septa because of the lymphangitic carcinomatosis, and you can have as well air embolism, as seen here, in patients who were placed intravenously with contrast, or we can even say that the intravenous talc embolism is one of the is a non-thrombotic embolism because it is made by people who are addicted to drugs, and this is a pathological cut of a lung showing how the veins have intravenous talc, and this causes chronic, as you can see here, chronic pulmonary disease. There are other pathologies of the pulmonary vasculature, like the pulmonary artery stenosis. It can be classified in central and peripheral, and it can be classified in extrinsic and intrinsic. In this case, we have an extrinsic cause of pulmonary artery stenosis made by a bronchopulmonary cancer. It was made by a cancer. And this is an acquired form of a congenital pulmonary artery stenosis. You can see here the tapering or the diminishing lumen of the pulmonary artery. We can also have pulmonary artery tumors. Like in this case, it was said that it was a sarcoma of the pulmonary artery. It was a primary artery sarcoma, and there are different type of tumors. They are really rare, but they always have to be taken in mind in people with cancer suspected etiology. We can have an angiosarcoma, rhabdomyosarcoma, and many others. Pulmonary sequestration is another type of pathology that we can have in arterial diseases, and is characterized by a portion of the lung that has no connection with the bronchi or pulmonary arteries, and it derives its major blood supply from an aberrant system, and it's explained here, like in this angiography. We can see an anomalous large artery in this arrow that goes from the thoracic portion of the aorta and opacifies a portion of the lung parenchyma, and this goes to the veins, the normal pulmonary veins. In here, we can see the opacification of this same patient. And well, to end off the class, we can talk about pulmonary aneurysms and pseudoaneurysms. Their etiology is vast. This is a case we had here in our service of a girl who had endocarditis, and this tricuspid endocarditis to be specific. And this girl, after some chronic treatment, developed some vascular pulmonary aneurysms seen here in this coronal and this sagittal angiography. Coronal CT, coronal contrast CT, enhanced CT. There are different types of pathologies that can give us a pulmonary artery aneurysms, and it can be true or false, as we know. And as you can see here, infection is one of the main causes of false aneurysms. This girl unfortunately died. So, well, thank you for your attention. I hope you like our thing, our lecture. Just for all the YouTube watchers, please subscribe and like, and feel free to leave your comments on the section below. They told me not to watch on the camera, but I'm gonna say hello. Thank you very much. Yeah.